someone's advice, praying it'll bring you back to me. Designed for radio static, I start hearing your voice reply, almost like you're right here with me. So don't tell me when it's over, I don't wanna know. I'm done carrying the weight of the world so heavy on my shoulders. I just wanna feel this love, even if it's only when I'm tripping I see your face. I ain't doing no one a favor while I'm sober for the moment. I can only hope this lasts, 'cause when the high stops, then I know that you're gone. So stay and hold me like a paperweight, kiss me like it's all the same, just lovers like we were supposed to be. Oh, as these shapes and colors all start to fade, I can feel you slipping away. Just promise that you'll wait right here for me, until I find another dose. Won't make it on my own. I'm done carrying the weight of the world so heavy on my shoulders. I just wanna feel this love.
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
Welcome to another episode of True Abutment's Interview. I'm Jeff Kraft, and on this episode, I've been fortunate enough to get the invite and travel out to beautiful Wake Forest, North Carolina to experience a retreat unlike any of its kind in the dental industry. Now, I'm going to sit down with Dr. Tarun Agarwal, founder of 3D Dentist, and find out how his CE programs have become such a powerful tool for dentists. Now, 3D, they've held CE courses and retreats in the past, but this particular one is a step above the rest.
You're staying with your instructors, you're staying with your mentors, eating dinner together, we're breaking bread, where the real conversations happen.
Wow, it's beautiful, it's relaxing. Just really gives you that confidence and that ability to ask questions.
My opinion, a higher level of dentistry, because that's why we're here.
Yeah, the living room, the family room, the hot tub, you know.
Seen space like this in a while.
So I already know that their courses are fantastic, so I already know that I'm going to get the best.
That's what we've always done that set us apart from some other educational opportunities. And dentistry has so many great educational opportunities out there.
Hey, Jeff, we talked about this today. Tell me, how did you get through this, and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee.
So getting the invite to come out here, Dr. Agarwal, first off, it's amazing, just coming down the driveway.
Thank you.
What made you pick this location?
Well, Jeff, thank you for having me on, but I want to be referred to as T-Bone, so please call me T-Bone. That's what everybody else calls me.
Yep.
My wife calls me other names, but it was a pipe dream. There was the dream that we could have a place where dentists could really immerse themselves, but I never really believed it would happen. I never, felt that we would find the right property or that we would build the property. And one day my wife was looking, I don't know what she was looking for, probably a place to live and hide from me, but my wife was looking for some real estate and she came across the property. I got to give her all the credit. She pushed me. I said no initially. There was a lot of fear about putting myself out there, making the investment, doing something that frankly is pretty, if not completely unique, or pretty damn unique within the dental profession. So we pushed it. I believe that what's happening in dentistry is there's a significant move to corporatization. There's some pluses and minuses to that. There's a lot of move towards a pure business aspect of dentistry, and there's a lot of value in all of that. But who's getting left behind is the single location solo practitioner. And there's not a lot of places for them to go and really geek out on dentistry, to really surround themselves with people that are looking for the same things they're looking for. I like to say that there are a lot of places that do phenomenal education. We try to make impactful education. We want to impact people's practices, and more importantly, we want to impact how they live their lives so that they can enjoy it.
Tell me the courses that you cover here on this property.
So the way we look at it is it's a three-step process, okay? You got to slow down to speed up, you got to create clinical diversity, and then you take back control of your practice. You know, a lot of us, we've lost control of our practice, and we blame it on insurance, we blame it on competition. Ultimately, we just got to blame it on ourselves. I mean, it's our names on the door. To slow down to speed up is our case acceptance process. It's about understanding that it starts with diagnosis, it includes a influential communication with your patients, learning how to make dentistry affordable for patients in the modern world, and then creating a schedule that allows you to actually do the dentistry that you're learning. That's slowing down to speed up. The next part of it is we got to create clinical diversity. Dentistry has become a commodity product if you're maintaining in the general dentistry world. Now, I'll be the first to say that you can make a phenomenal living and live a great life being a traditional general dentist. But it's harder and harder now. What was easy, what worked for me in 1999 and 2000 isn't working today. It's just different. These young kids, they're phenomenal. They're getting out there, they're doing it. A lot of it's by force because of the debt they incur, but they're making it happen. So we focus on clinical diversity. We focus on dental implants, sleep apnea, orthodontics, dental oral sedation. We focus on medical billing. We focus on the things that allow you to grow your practice without necessarily having to physically grow your practice. What I think we're extremely good at is not just the clinical education, but the business nuances that go with it, the practical business nuances, because we're all practicing dentists. We're all owners. We're not specialty general dentists. We built a practice that's a broad range of general dentistry. And what it takes to recreate that, we try to teach the business principles that helped us be successful, that creates a well-rounded practice. And then we work on being supportive, to helping people move forward, and that's where we help them take control of their practice, to take back control at whatever level people are at. We try to meet people where they want to be.
Who is the right dentist to come to a course that you offer?
That's a great question. It's a tough question to answer for me because I want to say everybody, but it's not everybody. I would say first and foremost, it's someone that is looking for something different. They're unhappy with something that's happening in their practice. Whether it's how busy they are, how much money they're making, how little time they get off, or the type of dentistry that they're doing, or whether it's a young dentist that says, I want to achieve that level of dentistry. That's our customer, the person that wants better. I don't believe we're best suited for somebody that's really struggling and looking for a magic bullet, because we don't have magic bullets. I don't believe in magic bullets. We don't have magic bullets. I believe it takes grit, determination, and hard work to get there.
When dentists arrive from all over the country, what's their first impression through your eyes?
Well, what we've heard so far is it's better than they expected. The pictures don't do it justice. I'm hopeful some of these videos will help people see the vision and the difference. I don't think anything like this has been done, where we're immersed, where you're staying with your instructors, you're staying with your mentors, where we're cooking breakfast, where we're eating dinner together, we're breaking bread, where, listen, we're going to have fun and have some ice cream together, where the real conversations happen. The outside of the classroom. Hey, Jeff, we talked about this today. Tell me, how did you get through this, and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee. And I saw it the other night. There was 4 conversations going on in 4 different areas of the lodge, where we have a group talking about business, then we got a group talking about individual younger guys and gals talking about their specific situation, and people just migrate to each other, and you pick up so much by just being around things. You know, they say you're the average of the 5 people you hang out with. Here you get to hang out with people that are really motivated and driven, and it raises your average.
The support that you've created in this program goes beyond the walls through the follow-up. Talk to me a little bit about that as well.
You know, there's a saying that only 10% of your attendees actually do anything. And I don't think it has to be that way. We just need to provide a support system for them to not make it that way. Because here's the truth. You leave here, you're excited, you're like, I can do this, and then Monday morning hits you. And it's nice to have a support system where people are saying, hey, it's okay. Like they'll get a text from me on Monday saying, I'm sure today wasn't what it was like for us this weekend, but I want you to keep the bigger picture in mind. Let's keep moving forward. Then I also think there's a competitiveness in each of us. And when we see, you know, of the 12 doctor attendees we had today for our live patient program, I think when they see that other person getting it done, there's a little bit that pushes them, hey, I don't want to be behind. So in a way, we're trying to create that environment, and we're trying to meet people where they're at. You know, I am committed to not make it a social media group because that invites too much distraction. I try to keep it right now it's a text group. Soon we're going to have our own mobile app where we can communicate with people and have video conferencing and everything with that. And what I think we've done well is it extends beyond the course. It extends for months and months and years of that text environment, of that support system. And I run into people who are on CE trips with their other colleagues that were in the class with them. They're talking about these challenges, and somebody said, oh, I had that same thing happen last month or last year. Let me walk you through what we did. And there's so much learning that happens, you know, and that's what we're trying to do. We're trying to create an environment where people learn.
What's the relationship like with True Abutment? How did that start?
You know, True Abutment's been a great partner of ours, okay?
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
Oh yeah, so actually I didn't expect I have the DDS and DMD as well.
How do you have both?
Because I got my first DDS degree in Korea first, and then came here.
Okay.
While I have to make a living, so I went to dental school again. That's why the
IDS program?
yeah, I went to Tufts Dental, and then they issue the
Only for 2 years, right?
yes, fortunately, yeah, they issue the DMD instead of the DDS. Yeah.
So your DDS from Korea,
Yes.
DMD's here,
Yeah.
and PhD's from Korea.
Yes.
Doctor, would you like all the lights off, or do you want to leave them?
I'm okay. Yeah, I'm okay. So 그냥 시작하면 되는 거야?
네, 이제 시작하시면
그냥 나도 이렇게 전혀 의미 없었구나. Okay. Okay. Thank you for coming to True Abutment Digital Academy. I'm Dr. Choi, and then thank you. cone beam CT in your office? Another 3, and then 30%. And then what about the intraoral scanner? 4. And then who has some experience with the computer-guided surgery at this point? Okay. All right. So everybody wants the successful results whenever you place the dental implants. But I would like to say the starting point is the how to place the implant on the ideal position. So if you want to get the successful results, such as the cosmetic function and longevity of the crown, we have to know how to place the implant on the ideal position. So, well, if the implant position is acceptable, actually it is not much difficult to get the at least a decent looking restorations. So actually that patient is quite old, around, that patient came to my office around 2 years ago. He was already 82 years old. So his chief complaint is, okay, Dr. Choi, I want a new teeth. I just want to hug my grandchildren. I was a little bit puzzled. What does it mean? I want to hug my grandchildren. So actually he got his implant in foreign country around 9 years ago. And then, but somehow, his previous dentist never finished his final restorations, believe it or not, for 7 years. And then he came to the United States. And then, well, on panel, what I found is, actually, what do you think? The position of the implants. Yeah, that's what I'm saying. Yeah, not too bad, actually. Yeah. So and then the patient has some bone loss here and there, considering the fact the implant was placed around 10 years ago. Actually, not too bad. Yeah, I totally agree with you. But when I opened his mouth, I was totally shocked. It's amazing. Yeah. So let me introduce the temporary crown, which was never broken for 7 years. It's a miracle. Yeah. So anyway. So this is the final restoration. Even though the patient has a little bit of the problem in the maintaining the oral hygiene, and then, well, patient is over 80 years old, and then the patient already got the bone loss here and there. The result was not bad, and then also patient can hug his grandchildren. Yeah, it is really good. Yeah, but the implant position, when the implant position was not acceptable, actually we cannot expect anything. So this patient is around 32 years old female. Yeah. So I don't know how the previous dentist can handle these patients, but well, I would like to say nobody can make the good restoration on these implants. So the point is the ideal implant position. Actually, the information about the ideal implant position is pretty much well they're documented 3-dimensionally. Yeah, once you Google it, you will get all the information. But let me have the quick review. So the patient comes in with the broken tooth number 10. Of course, I took it out and placed the implant. So once again, 3-dimensionally, the number is well documented. The labial buccally, we have to leave at least 1.5 millimeter of the bone, and then at least 2 millimeter. Nowadays, more the better. Lots of people recommend at least 3 millimeter. And then also the mesiodistally, we have to leave at least 1.5 millimeter of the bone from the natural tooth. And then if you want to place implant in a row, we have to leave at least 3 to 4 millimeter of the bone. Yeah. And then occlusal apically, so the top of the implant platform must be positioned in 3 to 4 millimeter from the soft tissue and 1 to 2 millimeter from the crystal bone. Yeah, that is the standard numbers. And then as far as you can keep this number, well, actually, it is not much difficult to get at least decent looking restorations. But When you are in good mood, even though the patient like that, she has totally terminal dentition. She has totally so-called terminal dentitions. It is not much difficult to place the implant with your free hand on the ideal position with the good results. Not a big deal. But problem is when you are in bad mood, sometimes your implant might go into the nerve, or sometimes your implant threatens the facial artery. Sometimes, if you don't respect the biologic width, 2 to 3 years later, all the bone between the implants will be breaking down. Or sometimes, if you are distracted, your implant might be positioned in totally unrestorable position. Yeah. So if you want to be a good implantologist, at least you have 2 abilities. First ability is you must able to place the implant, how to place the implant on ideal position. And the other ability is you must be able to maintain your quality of life, the quality of the treatment. So how can you place the implant on ideal position? We have a couple of options. The first option is, still with our free hand, we can place the implant on ideal position. But in order to do that, first of all, you have to do lots of study. And then, more difficult thing is, you have to get through the lots of trial and error with lots of stress. That is the difficult part. Another alternative is using the computer-assisted surgery. Still, unfortunately, you cannot avoid lots of study. You have to do study. But the little bit good thing is we can skip lots of trial and error and lots of stress. Nowadays, we have 2 kinds of implant-assisted surgery. The first one is a computer-guided surgery. The other one is a computer-navigated surgery. Computer-navigated surgery is called the dynamic surgery because we can change the implant position during the procedure. That's why it is called dynamic surgery. But the computer-guided surgery, another name of the computer-guided surgery is called the static surgery because everything is determined. We cannot change the implant position or angulation, anything. We cannot change anything during the procedure. Only what we can do is just make an osteotomy and then place the implant. Nowadays, the computer-guided surgery is much more popular than the navigated surgery. Simply to say, it's much more easy and intuitive, and then we don't need to buy the expensive machine, as you see in the bottom right side. That is the main reason. So what is the difference from the computer-guided surgery and then traditional guide? The traditional guide. So in the surgery with the traditional guide is still we have to consider lots of things during surgery. So is my implant position is correct? Do I still have the 2 millimeter on the buccal, or my implant is too deep or shallow? During surgery, we have to think lots of things. But in computer-guided surgery, so we already considered everything before surgery in the computer. So even the size of the implant is already decided, and diameter of the implant is decided, angulation is decided, even the hex structure of the implant connection is already, the direction of the hex structure is already decided. So once again, what you have to do is just place the implant with the surgical template. So once again, because everything is already decided, if you design the treatment plan as an immediate loading, after surgery, we can just put the custom abutment and then put the temporary crown right away with the minimal adjustment. That is the beauty of the computer-guided surgery. So in order to get the computer-guided surgical template, so we have to, this is the workflow to get the surgical guide. Yeah, so I just picked up this picture from the URIS website. Looks nice, but a little bit complicated. So I just trim it down. So what you have to do is getting the information from the patient and send out to the company and then company will fabricate the surgical template for you. So once again, what you have to do is just place the implant according to the surgical template. That is the thing you have to do. But so before explain the data the collection, I'm gonna review short review of the basic information about the cone beam CT and then intraoral scanner. I think everybody pretty much know that information. So we have two CT. One is the dental CT and medical CT. The dental CT is called the cone beam CT because shape of the beam is a conical shape. The advantage of the cone beam CT is they have quite the low X-ray exposure, but the downside of the cone beam CT is diagnostic power is quite inferior to the medical CT. And then another thing you have to know before purchasing the CT is, well, we have the term field of view. It is related with the size of the image. So if you want to ortho treatment in your office, you have to buy the CT with at least 15 by 15 inch of the field of view because you have to take a cephalogram. But if you want to just the implant treatment, we just need from here to here, right? So we need to purchase the CT, cone beam CT, with the 12 by 8 inches of the field of view. Yeah. And then another big difference between the image between the cone beam CT and then the normal panel is the cone beam CT shows the metal artifact. So if you take the CT of the patient with some kind of hard material in their mouth, in the patient's mouth, sometimes you can see some black lining along the implants. And then many people think, okay, this implant is failed, it is soft tissue encapsulated. Maybe yes, but maybe mostly not, because it might be just an artifact. Or sometimes you can see some white streak or white bursting the image around the metal crown. So all of them is called a metal artifact. And then, so it's a well-known story. The CT tells a lot than you think. So every CT has the deviation value, and then that deviation value is different from the company to company. Medical CT is quite better, but still, they have the deviation values. So all the image in medical field must be saved in some kind of file format. We call it DICOM file. So it's an abbreviation of the digital imaging and communications in medicine. And so I'm not just talking about the CT. The medical field has a lot of imaging systems, such as MRI, sonar, or PET scan, or whatever. And then all the image must be saved by the regulation in DICOM file. And then, which means medical people want to retrieve their file anywhere, at any time, as far as they can access the internet. And then, to run this DICOM file, they made some software system. We call it PACS. Unfortunately, the dentistry is a part of the medicine, but the PACS and DICOM system is not fully implemented in the dentistry, except the dental school or a big hospital-based office. Yeah. So when you send the CT file to the lab, you must not send this one. You must not send this file. You have to, somewhere in your CT machine, there's all the cone beam CT has the function extract DICOM. When you click the extract DICOM, you can get your CT machine can generate this kind of file. Lots of file with extension DCM. So you have to send this file to the lab, not this file, to make the surgical template. So intraoral scanner is now getting more and more popular nowadays. And then nearly half of the people already uses the intraoral scanner. And then it's just a simple device to take the optical impression of the patient's mouth.
Is that
So,
the one you use? The Medit?
yeah, it's a medic.
That's the one you use?
Currently, yes. What do you use?
The Sarah.
Sarah? Expensive one. Yeah. So actually, this is the image is not the surface file, produced by the intraoral scanner. It's a CT file, 3D CT file. But as you see in this CT file, we can see everything. The shape of the tooth. As far as we can see the shape of the tooth, technically we can make the surgical template, but actually, practically we can't, because even though we use the most recent updated cone beam CT, still the CT is not accurate enough to produce the occlusal surface of the occlusal surface of the tooth. And also, nowadays every patient has at least one metal crown in their mouth. So once again, because of the metal artifact, we cannot clearly define the shape of the tooth. That's why we need another device. That's why we need intraoral scanner. So the mechanism of the intraoral scanner is a little bit complicated. Actually, in the intraoral scanner, there's a beam projector and then two very nice camera inside. When the beam is projected on the surface of the 3D surface, so the two camera captures the reflection of the light and then recognize the surface as the lots of small dots, lots of small points. We call it point cloud, makes sense? And then the software of the intraoral scanner makes the small triangles using the lots of points. And then covers the surface with the triangles. We call this process, covering the surface with the small triangles, tessellations. So that is the final product you can get. So you can see the lots of points with the lots of triangles. And then, as you see in the picture of the intraoral scanner, the field of view, the tip of the wand is quite small as our thumbnail. So the size of the file is this thumbnail size. The software of the intraoral scanner combine the files, lots of small files, into the one big files. It is exactly the same as the panoramic function in your iPhone. So we call it image stitching. And then the surface file can be saved in some file format. One of the most common file format in dentistry is the STL file, the abbreviation of the Standard Tesselation Language. So once again, the tessellation is the process to covering the surface with the small triangles. That small triangle is called tiles or faucets in many names. So this is most of the common file name. And then the advantage of the STL file is size of the file is quite small. So it is really useful to produce the printout or milling some product with speed. Okay? But the downside is in order to keep the file size small, they sacrifice a lot of characteristics, surface characteristics, such as the color and texture. So that's why the STL file looks gray like that. So if you want to keep the surface characteristic, well, you can download that surface file into another file format, such as the OBJ and then PLY. Yeah. And then when you read some of the paper related with the intraoral scanner, you will meet some kind of new vocabularies. I'm going to just introduce the three things, which are the accuracy, trueness, and precision. So let's see. There's a tooth, and then you scan 3 times. Scan 1, scan 2, scan 3. So this is the real information of the tooth, and then this is the scan information. So, but unfortunately, real tooth information is different from the scanned information. That difference is called trueness. And then I said I scanned 3 times, but each scan data might be different. The difference of each scan data is called precisions. And then accuracy is the general term to evaluate some of the accuracy and trueness. But in the paper or in some information, sometimes the dentists they misuse the accuracy with they have to just confuse the word accuracy and trueness and precisions. So you have to read between the lines. We have many factors affecting the accuracy of the intraoral scanner. Well, resolution, of course, it can affect the accuracy, and then the software makes sense, capture size and stitching. At every stitching process, we have the error. But once again, there's a tooth, and then scanned 3 times with one scanner. But as far as you can use the one scanner, the resolution will be same, and then software is the same, and then size of the capture and the stitching is same. And then if you scan the data on the desktop, not in the patient's mouth, we can also control the moisture and illumination. Still, we might have the different data at each scan, because main reason of the mistake is happened by the dentist. So if you scan these kind of things, you can scan like that, or you can scan like that, or you can scan like that, right? This scan motion, this kind of scan motion is called strategy or a scanning sequence. Yeah, maybe that's why in intraoral scanner we have more error than the desktop scanner. So, okay, let's go back to the surgical guide again. So we have to collect the data. So depending on the patient's situation, we have 2 strategies. If the patient is a partially edentulous, we use the single scan technique. But the patient does not have any teeth, fully edentulous case, we have to use the dual scan technique. The single scan technique means we have to take just one scan, one cone beam CT scan. And then dual scan technique, we have to take the 2 cone beam CT scan. So let me talk about the single scan technique first. So when the patient comes in with the partially edentulism, we have to collect the data, soft tissue data, and then bone tissue data. The hard tissue data can be obtained by the cone beam CT and must be saved into the DICOM file. And surface file, the soft tissue file, can be obtained by the intraoral scanner and then can be saved into the STL file. But if you do not have the intraoral scanner, or if you are too busy to use the intraoral scanner on that day, maybe you can ask your DA to take the impression with the rubber material and then pour the cast. And then if you send that cast into the lab, well, the people in lab will scan the stone model with the desktop scanner, and then retrieve the information and saved into the STL file. Yeah, so you have 2 options. And then we have the soft tissue data, and then we have the hard tissue data. We have to combine it. Okay, we call it merging or data registration, or just call it stitching. But in order to combine the 2 files, we need overlapping field of view, overlapping structures. Usually in single scan technique, we use the teeth as the common structure. So without the teeth on the both files, we cannot combine it. So we need clear image of the teeth in both files. In the intraoral scanner, no matter what, we can get a very clear tooth image, but in the cone beam CT, sometimes we can't. So when you take the CT to fabricate the surgical template, so we have to take the CT with opening the mouth. If the cone beam CT machine supports the bite block, it is wonderful, but if it does not, you have to put the cut roll in the back of the tooth and have the patient bite down and then take the CT. We have to disclude the occlusion. So in case of the dual scan technique, we don't have any teeth. So how can we merge the two files? First, and then before that, so we have to, dual scan technique means we have to scan 2 times with the cone beam CT. We have to take the first scan, cone beam CT, of the patient wearing the denture. But the denture already has some radiopaque material on it. I'm going to just call it modified denture. So once again, usually when you take the CT, we have to take out all the intraoral prosthesis and then take the CT. But to fabricate the surgical guide, it is not. Once again, we have to take the first CT of the patient wearing the modified denture. The second, and then we have to take the another CT, denture only, modified denture only. Okay, so this is the modified denture. I put the lots of radiopaque material on the denture. We call it fiducial marker. And then first CT, take this CT of the patient with the modified denture, and then the second CT is to taken by of the just modify the denture only. So when you modify the denture, when you put the radiopaque material, when you put the fiducial marker, so there's lots of ways, but the protocol of the US company is not like that. So they recommend they put the 3 markers on the labial side and the other 3 markers on the lingual side. So if you, the most affordable material is, any opaque material is okay. But the most affordable material in dentistry, dental office is, of course, composite. Yeah, you can just apply the bonding machine on the denture and then apply the packable or flowable. Anything is okay. Yeah, around 2 millimeter height, and then that's it. And then, so if the denture fits very well on the patient's soft tissue, we don't need to rely on it. But if you think if the denture has the gap between the tissue, we have to rely on it to get the better demarcation line of the soft tissue. So usually the patient uses the PVS, usually heavy body, but personally I prefer bite registration material, blue mousse, yeah, because it's a quick setting, yeah. And then, if you want to put the little bit fancy way, you can purchase the sticker type, the commercial fiducial marker, like that. The most well-known company name is the Suremark. So yeah. And then this is the first scan, and this is the second scan. And then with the fiducial marker, we can combine the 2 data. So problem is, I have to make you a little bit confused. Okay, problem is, what if patient has lots of the metal crown in their mouth? When you take the CT, once again, because of the metal artifact, you cannot define the shape of the tooth, even though you take the CT of the patient with mouth opening. Okay, so in this case, we have to put another fiducial marker, another radiopaque marker on the occlusal surface of the metal crown, or inside the edge of the metal crown. And then we have to take the CT and then scan by the intraoral scanner. So in this sense, well, I mentioned about the two options in the single scan technique. We cannot take the. It would be better not to take the rubber impression material because the radiopaque material will be dislodged during taking the impression. So eventually, you have to purchase the intraoral scanner if you want to keep your practice with the surgical template. So this is the CT machine, the CT image, and then you can clearly see the two radiopaque material on the occlusal surface of the metal crown. And this is a surface file. You can see my ugly composite buildup on the occlusal surface. And then this is the anterior case. So, well, as you know, the number 7 must be out, and then CT image, there's a lot of blurring because of the metal crown, tooth number 8, 9, and implant 10. So in this case, so the little bit confusing, I said you have to put the radiopaque material on the incisal edge, not on the facial, not on the lingual. So another problem, what if the patient has only one tooth on the one side? Technically, patient is an edentulous patient, but patient still have the crown supported by the 2 implants. Of course, we have to put the radiopaque material on the surface of the crown, like that. But once again, the basic protocol about how to put the radiopaque material is, we have to put the radiopaque material in well spread out way. You have to put anterior, posterior, well evenly, okay? So in this case, we have to put another radiopaque marker on the other side, surprisingly on the soft tissue. So, and then another thing I found is just to apply the bonding on the soft tissue and then put the fluorable composite works really well. And then, well, if you want a little bit more fancy way, you can just buy the temporary stopper and then cut it and then put it on the soft tissue with the crease glue. It works also very well. But try to put the radiopaque marker on the attached gingiva. Movable tissue is a movable tissue. So the location of the radiopaque marker might be changed by the expression of the facial muscle. And then now you have the DICOM file in the left hand and then STL file on your right hand. So what is next? Of course, you have to send the data onto the website of the company. So the whichever company you use, basic format of the website is nearly same. So they will ask your information and the patient's information, and then of course they might ask your card number, and then ask the soft tissue data and hard tissue data. After that, you will get the thank you sign like that. With this information, company merge the 2 data and then figure out where the bone is, where the vital structure is, and how you can angulate the implant, what is the best size of the implant, and what about the diameter of the implant, decide everything. And then send you the temporary treatment plan. And then if you say okay with the temporary treatment plan, based on that, the location of the implant, they will fabricate the surgical template. And also, if you want if you design the treatment plan with the immediate loading, well, they will fabricate the abutment and then provisional restoration as well. And then, if you don't like the treatment plan, of course, you have to fix it, okay? So, at that time, you must express your philosophy as a dentist. Let's see, we have to place the implant in the front side. Sometimes they want to place the implant towards the cingulum area because they want screw retained restoration. But sometimes they just want to place the implant in the pressed-in bone So, and then they are okay with the cement retained restoration. Or sometimes they want to place the implant towards the inside the edge area and then finish the crown with the screw retained restoration with the angulated screw channel systems. So everybody knows the angulated screw channel system, right? It's okay, right? Okay. Okay, let's go path. Yeah. So once you are okay, and then so just sign it and then send it back to lab, and then they will and finalize the treatment plan, and then the lab will fabricate the surgical template. So how the professors love the classification. Well, we have two ways to fabricate the surgical guide. One is a subtractive way, and the other one is an additive way. But it is nothing, just a milling and 3D printing. And then, but if you want to use make the surgical template through the company, usually they will use the 3D printing because it is more appropriate for mass production. We have lots of ways. Well, SLA or DPL or LCD, lots of ways. But basically, mechanism nearly same. That machines are just the selective light curing machine, layer by layer, nothing else. And based on the point of view, we can classify the surgical template in many ways. So according to the supporting tissue, we have the tooth supported surgical template. Usually it is for the partial edentulous patient, but if the patient is the edentulous patient, well, we have the tissue supported, and then we have the bony supported. Well, somehow, if we have to open the tissue, the surgical template will be laid on the hard bone. That's why it is called the bony supported surgical template. And then tooth supported surgical guide is most known as accurate, and then bony supported surgical guide is the least accurate. And also, if you can use the surgical template from the A to Z from the procedure, for example, the initial drilling, the pilot drilling, and then sequential drilling, and then even you use a surgical template, a placement of the implant, we can call it fully guided surgical template. But if you just use the surgical template during the procedure, for example, initial drilling, the pilot drilling, the sequential drilling, and then take out the surgical template and then place the implant with your free hand, we can call it partially guided surgical template. And this is the fully guided pylon kit. So, according to the sleeve structure, we have another classification: sleeve guide, sleeve guide, and sleeveless guide, and then open sleeve guide. This is the typical shape of the sleeve surgical guide. You can clearly see the metal sleeve embedded in the plastic surgical template. And then this is a sleeveless. We cannot see the metal sleeve inside in the surgical template. It is much more easy to fabricate. So if you want to fabricate the surgical template in your own office, maybe you might use the sleeveless guide because you just need the metal structure. You just need the 3D printer in your office. But the downside is because of the drilling hole is just surrounded by the plastic. When you drill down, if you carry your drill in proper angulation, you might deform the surgical hole. So which causes eventually you will get the more angular deviations. And then another information is you must not autoclave the surgical template. So you just soak it in the chlorhexidine for the 5 to 10 minutes before surgery. That's enough. And then, so first time when you get the surgical guide, the dentists have some the concerns about the surgical template. The one is the overheating issue. The other one is the limited usage of the mouth opening limitation. So, because all the surgical field is covered by the surgical template, so the dentists are worried about the overheat because they are afraid of the irrigation system might not working. Actually, it is true. When we measure the temperature in the freehand technique and the surgical template technique, regardless of the irrigation system, whether you use the external irrigation or internal irrigation, the temperature of the surgical template group is much higher than the freehand technique. But the good news is the elevated temperature does not go to the critical point. So simply to say, statistically, there's no significant difference in the success rate between the two groups. Another problem is basically the guided drill is, as you see in this picture, is quite longer than the conventional drill. So we can easily expect, okay, we might have some problem to approach in the second molar area. Actually, the length of the guided surgical drill is nearly same as the conventional drill with the drill extensions. It's quite long. Okay, so nowadays some company manufactures the open slip type of the surgical template, which means they made just a big hole on the buccal side. So through the buccal wall, we can get the more irrigation water cooling system, and then also we don't need to approach the burr over the occlusal part. We can just carry the burr from the buccal openings. Another big advantage of the surgical template, the computer-guided surgery is we can execute a surgery with the flapless manner. So everybody knows if we don't open the tissue, we have the dramatically reduce the surgical time and then the post-operative discomfort. There's a lot of paper supports the flapless surgery can reduce the surgical time and the post-operative discomfort. So actually, Mrs. Gong came to my office before COVID, as you see on this picture. She has a lot of issues, especially in the upper. So her sinus is really large, nearly touching the nasal cavity, and then in between, there's some bone is just left, but it is also that area. Impacted canine has occupied that area, and then below that impacted canine, there's a floating tooth number 9, and then it's a totally through and through defect. So my treatment plan is of course, we have to take out the impacted canine, and then we have to fix the through and through defect, and then sinus bone graft to elevate augment the bone. So this is the labial view of the labial view. You can clearly see the head of the impacted canine, and then through and through defect of the tooth number 9. And then after extraction, you can see the nasal mucosa through the socket. And this is a lingual, the palatal view. After extraction, I can see the sinus membrane as well. So I started to make the window and then approach it little by little to the anterior area. And then the bone graft is done. And then the through and through defect was fixed. And then this is the post-operative X-ray, and then this is this is a post-op X-ray. And then we have a COVID. So the patient comes in around 10 months later after bone graft. So I place the implant in the bottom with my free hand, and then upper I use the surgical template, and then tissue was punched out, and then implant was placed by the protocol. And the first implant was placed, second implant placed, but just to see the flat surface of the manual ratchet is facing to the slip notch. Yeah, it's important. I'm going to tell you why. So, and then the another flat surface of the third one, flat surface is facing to the slip notch. So the surgery is done, and then this is the post-op. And then I asked the patient, okay, Mrs. Gong, how was it, the after bone graft in the upper? Oh, Dr. Choi, it is like hell. Yeah, I'm not going to do it anymore. Okay, so how was the pain or discomfort after placement of the implant in the bottom? Well, I have 1 or 2 days of the pain, but it is well controlled. It was tolerable. Yeah, it can be controllable with the analgesics. But how was the pain in the upper after placement of the implant? Well, okay, so I didn't get any painkiller. Yeah, I can do it every day. So I don't want to generalize everything with the one case, but well, we can clearly see the flapless surgery can reduce a lot of the postoperative pain. But actually, what I'm interested in is, well, I would like to say I'm pretty much well-experienced implantologist. I have placed over 12,000 implants over the last 10 years. But when I compare my implant location, angulation, and then everything, isn't it upper one is much better than the lower one? Yeah, it means a lot to me. Yeah, it means a lot to me. Once again, the implant location is the starting point of the implant success. So, but you can also combine the guided surgery with the open flap. So whenever you have a good reason to open the flap at the implant placement, yeah, you can combine it all together. Sometimes when you place the implant, you want to add a little bit more bone on the labial side, or, well, in case of the combination syndrome in the lower, usually the lower anterior bone is really high, right? So if you want to place the implant on there, we must cut the bone. So in this case, we have to open the tissue. Or if the patient is a very narrow attached gingiva, well, just using the punch is not a good idea. So the patient comes in to get the implant on tooth number 30, but the patient has a very narrow attached gingiva. So if you just use the punch, eventually your implant will get surrounded by the mobile tissue in the end. So that's why I just cut open the tissue, put the crystal incision exactly midline of the attached gingiva, and then open it, and then place the implant by the protocol. And then once again, the flat surface of the hand ratchet must be facing to the slip notch. And then I deliver the temporary crown on the same day of the implant. Yeah. So, of course, I just adjust the occlusion. And then this is the post-op. And then you can clearly see the attached gingiva around the final restorations. So from now, I have to make you a little bit more confused. So do you want to be confused before break or after break? Can I go? Or what time is it? 1:50. 1:50. Do you want to? Yeah, what about take a little bit break? Or do you want me to go? Okay. Yeah, let me go a little bit more. Okay. Let me talk about this slave offset. Yeah, it's really important concept in the computer-guided surgery. The slave offset is the distance from the top of the slave and to the top of the implants. Top of the slave and to the top of the slave. This is the offset distance. And then in slave offset, we have three structures. First one is the guide thickness. And then next one is the tissue thickness, and then in between clearance. That's why in normal conventional drill, drill stop is made at the crystal bone, right? Yeah. But the in guide drill stop is made at the top of the sleeve. Make sense? Yeah. So that's why the guide drill is always longer than the conventional drill. That's why we have some problem to approach the second molar area with the guide drill. So the URIS company provides the 3 different offset distance, which is the 9.5, 11, and then 12.5, increased by the 1.5 millimeter. But it is weird to say URIS company manufactures only one size of the drill, which fits for 9.5 only. So, but we have to understand why the URIS company provide a different offset distance. Actually, it is not the URIS company only. All the company manufactures a little bit different offset distance. That makes the dentist crazy. So, first scenario is lower anterior area. So the size of the tooth is quite small. And then actually we cannot physically put the 7 to 8 millimeter of the wide of the surgical metal slab between the teeth, right? Physically we cannot put it in, right? That's why we have to locate the metal slab above the occlusal surface. That's why we have the different offset distance. Make sense? Yeah. Another situation is, what if the tissue thickness is really, tissue is really thick, usually upper posterior area. So in this case, we have to locate the, we cannot make the surgical template touching with the soft tissue. Well, because of the tissue rebound, surgical template position will be changed. So we need clearance in between, no matter what. So in this case, no matter what, we have different offset distance. Another situation is when there's a big bone loss around the tooth. Physically, we can put the metal slab below the occlusal area. We can locate the metal slab around 9.5 millimeter above the occlusal, the crystal bone. But sometimes in this case, during the procedure, the head of the handpiece might hit the corner of the corner of the tooth or the plastic structure of the surgical template. That's why if you expect the premature contact, so we would be better to locate the metal slab a little bit higher. That's why we can have the different offset distance. Or in case of the multiple missing area, but because of the spatial limitation, if we cannot physically put the space cannot accommodate the multiple the metal slab, no choice. We have to put the one metal slab in the downstairs and the one metal slab in the upstairs. That's why in the same surgical template, they might have the 2 different offset distance. So you can clearly see the different offset distance in the one surgical template, right? Yeah. So let me tell you how to place the implant with one surgical guide in the 3 different offset distance. So if your surgical template is designed with the 9.5 millimeter basic offset distance, it's quite easy. Once again, the surgical drill is manufactured to fit the 9.5 offset distance. You can just pick up the drill and then just place the implant. Okay? Yeah, not a big deal. But if you have to place the same 10 millimeter of the implant with the surgical template with 11 millimeter offset distance, if the drill stop is made not on here 9.5, 11 millimeter. So drill stop occurs on here. If you just use the same drill, 10 millimeter drill to implant in this situation, you will end up with the little bit short osteotomy because steel stub is quite 1.5 millimeter high than the 9.5 one. So that's why you have to make the osteotomy with 1.5 millimeter longer drill. So the final drill should be the 11.5 millimeter. Can you follow me? Okay, so let's see. You have to place the 10 millimeter of the implant with the surgical template 12.5. The drill stub is made 3 millimeter higher than the basic one, 9.5 one. That's why you have to use the 3 millimeter longer surgical drill to place the 10 millimeter of the implants. Okay, do you have any questions? Okay, all right, let's skip it. Okay, so it's quite confusing, but actually it is not the problem of the US companies. So all the surgical template, the company in the world has the same problem. Okay, so my recommendation is, and also the company provide when you put the order, you will get the return product with the printed form of the surgical protocol. So, or you can download it from the company. When you really physically do the surgery, so print out the protocol and then put it in the wall, and then always double check the offset distance and then final drilling length. Yeah, that is the best way. Okay, so what about having a little bit of break? Okay.
Can we do like half an hour, a little more? The coffee's coming at 2:30.
Half an hour? Okay.
30 minutes. Thank you.
Are you okay? Really?
Brand new fresh coffee coming at 2:30. Thank you.
Sorry. Sorry, I have a coffee.
What's the difference between the pylon kit and the surgical kit?
Pylon kit and surgical kit?
Yeah, are they the same thing?
Yeah, the same thing.
Okay.
Yeah, I just talked about the
Pylon is divided and the surgical for the freehand surgery.
Oh, okay.
yeah. Oh,
This is the brand name.
okay.
The urex.
Yeah. Okay, so when you do the surgery, yeah, it's like the man-made one machine. So you have to follow the instruction. That is the best way, not to make some errors. So at a glance, the surgical protocol is quite complicated. And then at first time when I see this protocol, oh, I have to use lots of drills many times. Yeah, that is the first impression. But when I use it, when you use it, you will realize, okay, this one can be skipped. Okay, this one must be skipped. So actually, there's not much drilling procedures. And then the left side is the brief explanation of the drilling protocol of the pylon kit, and the red part is the difference from the conventional drilling. So let's look into the one by one. The first one, yeah, we don't need to use the number 15 blade. Open the tissue. Yeah, the tissue punch is enough to get access to the bone. And then, next step is the flat drill. We have to make the bone flat to prevent the next drill, migrated to another area. So also flat drill has the offset guideline. Just to carry the bird to the down to get to reach the flat surface of the metal sleeve by the offset guidelines. And then next one is the path drill. Path drill is just a 5 millimeter short drill. We have two kinds of path drill, diameter 2 and diameter 2.6. So making the 5 millimeter small, the osteotomy, can bring the full length drill more smoothly into the sleeve without the premature contact. And then, so I think it is really important. So if you want to skip it, definitely, but don't skip it. Sequential osteotomy is the same. It's just the widening of the drilling hole with the full-length drill. And then, so now the osteotomy is done. The next procedure is the placement of the implant. So the implant placement, the implant positioning, in implant positioning, we have two components. First one is the vertical component. The other one is the horizontal components. So when you do vertical control of the implant, when you place the implant on the right position, so usually in the freehand technique, we would be better to use the handpiece ratchet because rather than the manual ratchet, because the handpiece ratchet causes the less wobbling in the apex of the implant when you place the implant. But when you use the only handpiece ratchet to place the implant with the surgical template, basically don't do that. When you do that, eventually the handpiece ratchet will be stuck in the metal sleeve. Actually, it is really difficult to take it out. So when you use the handpiece ratchet, just use the handpiece ratchet to deliver the implant into the bone, and don't use over this line, which is the 6.5 millimeter of from the implant, the platform, the connection. But I usually use only that part. Yeah. And then next step, just use the manual ratchet all the way down until your planned the offset guideline can reach the top of the metal sleeve. So the next one is the horizontal components. We call it hex alignment or hex timing. Actually, the action is, so as you see, we have usually the most implant has the hexer structure inside. So we have to align the direction of the hexer structure of the implant connection. Otherwise, we cannot put the custom abutment on the right position. We cannot put the temporary crown on the right position, right? Yeah. So my point is, if you do not plan this immediate loading, actually we don't need to do that. Actually, this one is only to place the abutment on the right direction just after surgery. So that's why how to control the hex alignment, just to make the flat surface facing to the slip notch. That's it. So once again, if the hex position is aligned to the planned position, eventually, as you see in this picture, the abutment and restoration will be not in the right place. You will get this kind of results. So the patient comes in to get the implant in the bottom. So I took out the tooth number 29, 30, 31, and did bone graft. And then around 6 months later, I placed the implant with the surgical guide. You can clearly see the slip notch. And then tissue was punched out. Some bone is still is not consolidated, but not a big deal. And then I placed the implant by the protocol. And then you can clearly see the vertical control and then horizontal control, right? Yeah, so and then this is the 11 millimeter offset guideline, and the upper part of the silver is the 12.5 millimeter offset guideline. And then I just put the custom pre-ordered custom abutment. It is just right after surgery. And then I put the splinted type of the PMMA temporary the crown. Of course, we have to adjust the occlusal part. Yeah, so this is the lateral view. And then around 2 months later, I replaced the temporary crown with the full zirconium crown. And this is the occlusal, and this is the individual, the full zirconium crown. So let me give you some small tip. But usually, if you do not ask nothing, if you do not ask anything from the company, their default menu is to put the metal sleeve, the sleeve notch, facing just to the buccal side. But sometimes, because of the trick tissue, it is really difficult to see, oh, it is the right position, okay? So in this sense, mostly I ask the company to put the sleeve notch oriented to the mesial buccal side. We can get a better view at the hex timing. So another one is what I want to introduce is the stabilization system. In case of the edentulous case, we must use the anchor pin. I said in case of the edentulous case, we have 2 types of the surgical template. First one is the mucosa tissue supported surgical guide. The other one is a bony supported surgical guide. But the support and stabilization is different concept, right? So surgical template in the edentulous patient, it is like the complete denture. It is moving actually. So, but you have to place the implant in the moving the structure. It doesn't make sense. Okay, so that's why we have to stabilize the surgical template. And also, what if patient, this is a tooth supported surgical guide, but if the patient has a very long free end, we might expect some scissor effect during the surgery, right? So if you think you need it in case of the tooth supported surgical guide, we can get the additional stabilization, the system, which is the fixation pin and the fixation screw. This is the picture of the kit. So the usage is quite simple. So during the procedure, after make the osteotomy with the 2.0 pilot drill, you can just put this the fixation pin into the sleeve. That's it. So you can hold the surgical template into the bone. So this is the clinical picture. And then after placement of the implant, if you want to hold the surgical template into the implants, not on the bone, so implant is placed, and then if you want still make the another stabilization to place another implant, so you can just connect the fixation screw into the implants. Yeah, works really well. And but once again, those two, the fixation pin and fixation screw, it's a kind of option. Sometimes, even though the template is a free end, sometimes it is stabilized really well. It does not move in the patient's mouth. Usually, it does not move. But in case of the edentulous patient, no matter what, we have to stabilize the surgical template. So simply to say, it is nothing. It's just that we have to just nail the surgical template into the bone. That is the basic concept. So we call it anchor pin. So whether your surgical template is the tissue supported surgical guide or a bony supported surgical guide, all the surgical template for the edentulous patient has something on the buccal side. So we call it the anchor pin hole. Through the hole, we can use the anchor pin. It is protected by the drill stop. So you don't need to worry about the, okay, what if my drill is passed through to the lingual bone? But actually it does not happen. It is protected by the drill stop as well. So it's the same patient. So the patient has the two implant crown on the only one side. So the design of the surgical template is a tooth-supported surgical template, but we can expect some seesaw effect on here, right? So that's why I designed the surgical template with the anchor pin, even though it's just tooth-supported. So this is the picture of the design, but what you have to keep in mind is when you design the angle of the anchor pin, you would be better to put the angulation of the anchor pin 90 degrees to the bone. Once again, one of the reasons why we have to use the flat drill to place the implant is if you place the drill in the sloped bone, the surgical drill can migrate into the downslope. I think some of you who already use the place the implant has that kind of experience a lot. Okay, so well, if the anchor pin migrate into another area, your whole surgical template might be a little bit twisted, and then your final implant might have some more angular deviation. Yeah. So even though, this is the anchor pin zone, but you cannot clearly see. So even though I place the anchor pin, I'm still worrying about a little bit of the possible mobility of the surgical template. So that's why whenever I place the implant, I use the fixation screw to get the more stabilization of the surgical template. The surgery is done. And then this is the post-operative 3D CT. And then this is the one piece of the PMMA temporary crown. And then this is the final result. So this is the real surgical template for the edentulous patient. So this is it. I made the 3 anchor pin hole. And then, but when you have to nail the surgical template in the bone, how can you position the surgical template? It's another issue. So in old times, we just use our finger first. Some people say, okay, so just gently push it. Some people say, okay, you have to make the tissue blanched when we place the fingers. But anyway, so we are not 100% sure. So when I nail the surgical template with the anchor pin, well, we are not sure this implant, the surgical template is still, position is still maintained on the right position. So actually, there's no surest way, but so far, this one is the most updated way. We call it stackable bite guide. So this is a real surgical template, and then this is the stackable bite guide. You can just click in, and then you can take it out, clicks out, okay? So this is the combined form, and then, so you can just put the patient's mouth, and then have the patient bite down. The denture, the surgical template will be positioned correctly by the biting force. And then also, well, double check if the surgical template has some premature contact on some area, yeah, you also have to do occlusal adjustment to make the even contact, or you can double confirm the size with the bite registration material between the opposing tooth and then the surgical template.
What's the purpose of having the second piece?
Huh?
What's the purpose of having the second piece for?
This one?
Yeah.
Yeah, so just put the surgical template, but if you think, well, you can use your finger first to nail down the surgical template, but if you think it sounds like it looks like primitive, okay? So actually that is can be have a bite with the upper tooth. So we can give the even pressure to the surgical template, by having the patient to bite down the stackable bite guide.
Is that just to place the anchoring pin, or?
No, it's just I said it stays with the frictional force, so it clicks in, clicks out, like that. It's a combined part.
Yeah, so they, yes.
Okay.
More stabilization on the guys instead of a bigger pressing, and they press on one side and they make it tilted. So what he's saying is having the stackable guide, you're giving even pressure and then having the correct positioning of the surgical guide.
So the stabilization by the abiding force is better than the stabilization by our finger force.
And if they have no upper teeth, then?
Huh?
And if they don't have any opposing teeth, then what do we do?
You have to make a denture in the upper.
Wait, but are they biting?
Yeah.
Are they biting on the whole time while you're drilling?
Oh, no. After that, I have to take out. Yeah, and then you have to leave only this one, and then you just drill down. Yeah. Okay, so.
How do you put the anchoring pin?
Huh?
How do you put the anchoring pin in the drill, or?
Anchor pin?
Yeah.
Yeah.
Is it heavy?
Oh, no.
Piece or by hand?
There's some driver.
Oh, okay.
Yeah. So. Yeah, I'm sorry, I have used the term nail it. Yeah, so this is a drill bit. Yeah, and then as you see on here, there's a screw system. Yeah, just drill it and then use a tissue punch and then take out the anchor pin and then remove the tissue and then put the surgical template back and then re-put it in. Okay, yeah, before the real drilling. So okay, let me show you the short video, and then actually I gave all the information how to place the implant with the surgical template. Okay, so it's just a short video, and then before the coffee break. Okay, yeah. And then,
Did you get a provisional with custom abutments?
yes, I did.
The lab made the provisional or you made it?
Huh?
Did you make your own provisional or the lab?
No, I hit fabrication of the provisional crown by my hand. Yeah, so well, I just ordered it. Yeah, from the lab. Yeah.
The provisional?
Yeah, much better than mine. Yeah. And then, oops. Oh. Oops. Yeah, this is the 1 week later of the implant placement. Okay, what about having some a coffee break and then come back around 15 to 20 minutes later? Okay? Yeah.
Drinks already. We have a restroom. You have to have the implant right on the right spot so that the temporary will fit correctly, right? Remember, you said you don't have to do it if you're not doing immediate provision.
Welcome to another episode of True Abutments Interview.
Always invest in yourself. You have to be first.
Pursuing great dentistry requires cutting-edge technology, commitment, and community. Since 2006, CDOCS has been providing its members with hands-on training courses, lectures, and mentorship to achieve clinical excellence. Our comprehensive curriculum ranges from CAD/CAM to endo, cone beam, implants, ortho, and more. New content is updated on a daily basis. Our faculty come from nationwide to represent the very best of digital dentistry. We are CDOCS.
Our methodology is to basically show you how things are done, create a system, and then have you repeat the system. So you get a both didactic and hands-on portion to the training that we do. It's worked out well for over these 10 to 15 years, and people keep telling us how good it is and keep coming back. And even our mentors who mentor courses see the value of constantly upgrading their education with what we provide here. The changes that come with the new CDOCS is more of a complete education, hence the C, one of the C's in CDOCS. Before we were basically CEREC training, and then Dentsply Sirona approached us to do their cone beam training, so we started to branch out there. And then we started going into other avenues. So no longer are we just with CEREC and cone beam, but we also do endodontic training, clear aligning orthodontic training, and implant training. So we moved now from CEREC doctors into CDOCS, a more complete education. Well, from a true abutment standpoint, that's in our provisionalizing and restoring implants with CEREC course. We go heavily in depth with tie-based solutions, being able to restore implants, but also provisionalize, making sure we have the tissue ready for the final restorations. So that's where true abutment comes into play. But with everything else, we have a vast amount of education that we can do here, all the way from CAD/CAM to placing implants, to planning implants, to cone beam, to diagnosing with the cone beam endodontic problems, and then also utilizing that with clear aligner orthodontic treatments.
Oh, there he is. Mark, how you doing?
Good.
Oh yeah, fist bump.
Fist bump.
So I like what you've done with the place
Yeah.
here. This place is really nice. You know, when I walked in the door, it felt like I was walking into an Ivy League college.
When I first came here, I called it Dental Disneyland, and it made the impression on me right away. And then we serve 2 meals, breakfast and lunch for everybody that comes on campus. So got all the safety precautions and everything else here with the arrows and everything else.
Oh wow, look at this. This
Yeah,
is
so-
great.
And of course, being in Arizona, starting, I don't know, October or so, everybody sits outside, especially everybody from up north.
Yeah, absolutely.
They love the sun and everything else. So this is where we do a lot of our hands-on, especially with CEREC training.
Oh,
so,
this is amazing.
So once again, safety concerns, social distancing, and 3-to-1 screen up front, and this is where all the magic happens. Well, what CDOCS is planning for from an education standpoint, we'll continue with our hands-on, in-person training, but also we have a robust website that we're going to be doing some virtual trainings, some online trainings, self-guided trainings. So we have a whole lot we have planned in 2021 from an education standpoint. We'll give everybody different types of methods, how that enters into their practice, whether they want to travel, whether they want to stay at home, whether they want to have it done guided with an instructor, or whether they want to have it self-guided where they come and choose what they want to see.
You're staying with your instructors, you're staying with your mentors, eating dinner together, we're breaking bread, where the real conversations happen.
Wow, it's beautiful, it's relaxing. Just really gives you that confidence and that ability to ask questions.
My opinion, a higher level of dentistry, because that's why we're here.
Yeah, the living room, the family room, the hot tub, you know.
Seen space like this in a while.
So I already know that their courses are fantastic, so I already know that I'm going to get the best.
That's what we've always done that set us apart from some other educational opportunities. And dentistry has so many great educational opportunities out there.
Hey, Jeff, we talked about this today. Tell me, how did you get through this, and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee.
Gonna jump
No.
Oh, wow.
And B, you're loved, you're appreciated, you'll be sorely missed. You know your family, and you always have a family here with us. We love you.
I love you too. I'm not gonna ugly cry. I swear I'm not.
I am. I'm gonna
I really, really appreciate this.
So,
Thank you.
I know the next week is your last week, but you know, you'll always be with us, I think.
Yeah.
Hey, of course.
I really, really appreciate it. You guys, it's been fun. You said it would be. I fought this. I so fought this. I was like, I don't want to be a film.
She wanted to take a sick day today.
And you're still filming.
Episode of True Abundance Interview. I'm Jeff Kraft, and on this episode, I've been fortunate enough to get the invite and travel out to beautiful Wake Forest, North Carolina to experience a retreat unlike any of its kind in the dental industry. Now, I'm going to sit down with Dr. Tarun Argawal, founder of 3D Dentist, and find out how his CE programs have become such a powerful tool for dentists. Now, 3D, they've held CE courses and retreats in the past, but this particular one is a step above the rest.
You're staying with your instructors, you're staying with your mentors, eating dinner together, we're breaking bread, where the real conversations happen.
Wow, it's beautiful, it's relaxing. Just really gives you that confidence and that ability to ask questions.
My opinion, a higher level of dentistry, because that's why we're here.
Yeah, the living room, the family room, the hot tub, you know.
Seen space like this in a while.
So I already know that their courses are fantastic, so I already know that I'm going to get the best.
That's what we've always done that set us apart from some other educational opportunities. And dentistry has so many great educational opportunities out there.
Hey, Jeff, we talked about this today. Tell me, how did you get through this, and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee.
So getting the invite to come out here, Dr. Agarwal, first off, it's amazing, just coming down the driveway.
Thank you.
What made you pick this location?
Well, Jeff, thank you for having me on, but I want to be referred to as T-Bone, so please call me T-Bone. That's what everybody else calls me.
Yep.
My wife calls me other names, but it was a pipe dream. There was the dream that we could have a place where dentists could really immerse themselves, but I never really believed it would happen. I never, felt that we would find the right property or that we would build the property. And one day my wife was looking, I don't know what she was looking for, probably a place to live and hide from me. But my wife was looking for some real estate and she came across the property. I got to give her all the credit. She pushed me. I said no initially. There was a lot of fear about putting myself out there, making the investment, doing something that frankly is pretty, if not completely unique, or pretty damn unique within the dental profession. So we pushed it. I believe that what's happening in dentistry is there's a significant move to corporatization. There's some pluses and minuses to that. There's a lot of move towards a pure business aspect of dentistry, and there's a lot of value in all of that. But who's getting left behind is the single location solo practitioner. And there's not a lot of places for them to go and really geek out on dentistry, to really surround themselves with people that are looking for the same things they're looking for. I like to say that there are a lot of places that do phenomenal education. We try to make impactful education. We want to impact people's practices, and more importantly, we want to impact how they live their lives so that they can enjoy it.
Tell me the courses that you cover here on this property.
So the way we look at it is it's a three-step process, okay? You got to slow down to speed up, you got to create clinical diversity, and then you take back control of your practice. You know, a lot of us, we've lost control of our practice, and we blame it on insurance, we blame it on competition. Ultimately, we just got to blame it on ourselves. I mean, it's our names on the door. To slow down to speed up is our case acceptance process. It's about understanding that it starts with diagnosis. It includes a influential communication with your patients, learning how to make dentistry affordable for patients in the modern world, and then creating a schedule that allows you to actually do the dentistry that you're learning. That's slowing down to speed up. The next part of it is we got to create clinical diversity. Dentistry has become a commodity product if you're maintaining in the general dentistry world. Now, I'll be the first to say that you can make a phenomenal living and live a great life being a traditional general dentist. But it's harder and harder now. What was easy, what worked for me in 1999 and 2000 isn't working today. It's just different. These young kids, they're phenomenal. They're getting out there, they're doing it. A lot of it's by force because of the debt they incur, but they're making it happen. So we focus on clinical diversity. We focus on dental implants, sleep apnea, orthodontics, dental oral sedation. We focus on medical billing. We focus on the things that allow you to grow your practice without necessarily having to physically grow your practice. What I think we're extremely good at is not just the clinical education, but the business nuances that go with it, the practical business nuances, because we're all practicing dentists. We're all owners. We're not specialty general dentists. We built a practice that's a broad range of general dentistry. And what it takes to recreate that, we try to teach the business principles that helped us be successful, that creates a well-rounded practice. And then we work on being supportive, to helping people move forward, and that's where we help them take control of their practice, to take back control at whatever level people are at. We try to meet people where they want to be.
Who is the right dentist to come to a course that you offer?
That's a great question. It's a tough question to answer for me because I want to say everybody, but it's not everybody. I would say first and foremost, it's someone that is looking for something different. They're unhappy with something that's happening in their practice. Whether it's how busy they are, how much money they're making, how little time they get off, or the type of dentistry that they're doing, or whether it's a young dentist that says, I want to achieve that level of dentistry. That's our customer, the person that wants better. I don't believe we're best suited for somebody that's really struggling and looking for a magic bullet, because we don't have magic bullets. I don't believe in magic bullets. We don't have magic bullets. I believe it takes grit, determination, and hard work to get there.
When dentists arrive from all over the country. What's their first impression through your eyes?
Well, what we've heard so far is it's better than they expected. The pictures don't do it justice. I'm hopeful some of these videos will help people see the vision and the difference. I don't think anything like this has been done, where we're immersed, where you're staying with your instructors, you're staying with your mentors, where we're cooking breakfast, where we're eating dinner together, we're breaking bread, where, listen, we're going to have fun and have some ice cream together, where the real conversations happen. The outside of the classroom. Hey, Jeff, we talked about this today. Tell me, how did you get through this, and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee. And I saw it the other night. There was 4 conversations going on in 4 different areas of the lodge, where we have a group talking about business, then we got a group talking about individual younger guys and gals talking about their specific situation, and people just migrate to each other, and you pick up so much by just being around things. You know, they say you're the average of the 5 people you hang out with. Here you get to hang out with people that are really motivated and driven, and it raises your average.
The support that you've created in this program goes beyond the walls through the follow-up. Talk to me a little bit about that as well.
You know, there's a saying that only 10% of your attendees actually do anything. And I don't think it has to be that way. We just need to provide a support system for them to not make it that way. Because here's the truth. You leave here, you're excited, you're like, I can do this, and then Monday morning hits you. And it's nice to have a support system where people are saying, hey, it's okay. Like, they'll get a text from me on Monday saying, I'm sure today wasn't what it was like for us this weekend, but I want you to keep the bigger picture in mind. Let's keep moving forward. Then I also think there's a competitiveness in each of us. And when we see, you know, of the 12 doctor attendees we had today for our live patient program, I think when they see that other person getting it done, there's a little bit that pushes them, hey, I don't want to be behind. So in a way, we're trying to create that environment, and we're trying to meet people where they're at. You know, I am committed to not make it a social media group, because that invites too much distraction. I try to keep it right now it's a text group. Soon we're going to have our own mobile app where we can communicate with people and have video conferencing and everything with that. And what I think we've done well is it extends beyond the course. It extends for months and months and years of that text environment, of that support system. And I run into people who are on CE trips with their other colleagues that were in the class with them. They're talking about these challenges, and somebody said, oh, I had that same thing happen last month or last year. Let me walk you through what we did. And there's so much learning that happens, you know, and that's what we're trying to do. We're trying to create an environment where people learn.
What's the relationship like with True Abutment? How did that start?
You know, True Abutment's been a great partner of ours, okay? They've been supportive, but more importantly, their products are, I like to say they've created flexibility in my practice. I heard about True Abutment on social media. I reached out and said, hey, you know, I'm looking for a solution. I hear you guys have solutions. You know, can I learn more about it? They were generous enough to send me some stuff to make it happen. And I was like, why haven't companies come up with some of these products before? What is it that other companies aren't seeing? And what happens sometimes is companies get so big that they become hard to be nimble. And the one thing I'll say about True Abutment is they're very nimble. You know, I've talked to Jay, who's the person I deal with at True Abutment, and I say, you know what? I'd love a piece that works specifically with this implant. They said, you know what? We can make that happen. And then as we moved in on the CEREC side of things, they have phenomenal solutions. But as I've learned, as I've moved beyond some of that, is they have great solutions for other things. They make things flexible. They provide solutions to problems that we have, and solutions to problems we don't realize that we have. You're staying with your instructors, you're staying with your mentors, eating dinner together, we're breaking bread, where the real conversations happen.
Wow, it's beautiful, it's relaxing. Just really gives you that confidence and that ability to ask questions.
My opinion, a higher level of dentistry, because that's why we're here.
Yeah, the living room, the family room, the hot tub, you know.
Seen space like this in a while.
So I already know that their courses are fantastic, so I already know that I'm going to get the best.
That's what we've always done that set us apart from some other educational opportunities. And dentistry has so many great educational opportunities out there.
hey, Jeff, we talked about this today. Tell me, how did you get through this and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee.
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
Is the snake gonna jump out? Oh, wow.
And B, you're loved, you're appreciated, you'll be sorely missed. You know your family, and you always have a family here with us. We love you.
I love you too. I'm not gonna ugly cry. I swear I'm not.
I am. I'm gonna
I really, really appreciate this.
So,
Thank you.
I know the next week is your last week, but you know, you'll always be with us, I think.
Yeah.
Of course.
I really, really appreciate it. You guys, it's been fun. You said it would be. I fought this. I so fought this. I was like, I don't want to be a film.
She wanted to take a sick day today.
And you're still filming.
I've learned so much from before. Now I'm not short on advice. There's no excuses at all. No point in feeling upset. Won't take my place on the floor. I'll stand up straight like I'm tall. It's up to me, no one else. I'm doing this for myself. It's not the same anymore. It's better. It got better. It's not the same anymore, it's better.
It started with a kiss on your mama's couch. 2012 was nothing serious. And then we caught the feels. It got really real. Took it to be true. I guess I thought you was, yeah. Why did I run away, run away, run away? Oh, your love was everything, everything, everything. I know it's getting late, getting late, getting late. But can I still be on my way, yeah? touch her, I feel like I'm cheating on you, baby. Cheating on you, baby. When I touch her, I feel like I'm cheating on you, baby. No, there ain't no lips like your lips, and nobody else feels like this. There's no moving on, I'll admit, if you go away. Yeah, I know I said goodbye and baby you said it too. When I touch you, I feel like I'm cheating on you. I know I'd be better when I felt someone new. When I touch you, I feel like I'm cheating on you, baby. Cheating on you. When I touch you, I feel like I'm cheating on you. And you said goodbye. Borderline, there she goes on the left side. Merry-go round people, little white lights. I know that it's over, so where do we go? Where do we go? Oh, you know that I know that it's over, so where do we go? Where do we go? Oh, don't let the heartbreak hit you on a Saturday night. Come meet me halfway in between dark and the light. 'Cause the voice in my head said I ain't going back to my bed. Yeah, I'm alright. Adeline, hold the door as I walk by. We can fly and watch the floor as they live life. I know that it's over, so where do we go? Where do we go? Oh, you know that I know that it's over, so where do we go? Where do we go? Oh, don't let the heartbreak hit you on a Saturday night. Come meet me halfway in between dark and the light. 'Cause the voice in my head said I ain't going back to my bed. Yeah, don't let the heartbreak hit you on a Saturday night. Come meet me halfway in between dark and the light. 'Cause the voice in my head said I ain't going back to my bed. Yeah, follow me close. There's a light behind the door. I know that it's over, so where do we go? Where do we go? Oh, you know that I know that it's over, so where do we go? Where do we go? Oh, don't let the heartbreak hit you on a Saturday night. Come meet me halfway in between dark and the light. 'Cause the voice in my head said I ain't going back to my bed. Yeah, don't let the heartbreak hit you on a Saturday night. Come meet me halfway in between dark and the light. 'Cause the voice in my head said I ain't going back to my bed. Yeah, I'm alright.
The way you look when you cry made me wanna confess to you. The way you wear that dress like it couldn't mean less
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
Is the snake gonna jump out? Oh, wow.
And B, you're loved, you're appreciated, you'll be sorely missed. You know your family, and you always have a family here with us. We love you.
I love you too. I'm not gonna ugly cry. I swear I'm not.
I am. I'm gonna
I really, really appreciate this.
So
Thank you.
I know the next week is your last week, but you know you'll always be with us, I think.
Yeah.
Of course.
I really, really appreciate it. You guys, it's been fun. You said it would be. I fought this. I so fought this. I was like, I don't want to be a film.
She wanted to take a sick day today.
And you're still filming.
You're staying with your instructors, you're staying with your mentors, eating dinner together, we're breaking bread, where the real conversations happen.
Wow, it's beautiful, it's relaxing. Just really gives you that confidence and that ability to ask questions.
My opinion, a higher level of dentistry, because that's why we're here.
Yeah, the living room, the family room, the hot tub, you know.
Seen space like this in a while.
So I already know that their courses are fantastic, so I already know that I'm going to get the best.
That's what we've always done that set us apart from some other educational opportunities. And dentistry has so many great educational opportunities out there.
Hey, Jeff, we talked about this today. Tell me, how did you get through this and how did you implement this in your practice? Or attendee to attendee. It's not just about us. It's really not about us at all. It's about each individual attendee.
Pursuing great dentistry requires cutting-edge technology, commitment, and community. Since 2006, CDOCS has been providing its members with hands-on training courses, lectures, and mentorship to achieve clinical excellence. Our comprehensive curriculum ranges from CAD/CAM to endo, cone beam, implants, ortho, and more. New content is updated on a daily basis. Our faculty come from nationwide to represent the very best of digital dentistry. We are CDOCS.
Our methodology is to basically show you how things are done, create a system, and then have you repeat the system. So you get a both didactic and hands-on portion to the training that we do. It's worked out well for over these 10 to 15 years, and people keep telling us how good it is and keep coming back. And even our mentors who mentor courses see the value of constantly upgrading their education with what we provide here. The changes that come with the new CDOCS is more of a complete education, hence the C, one of the C's in CDOCS. Before we were basically CEREC training, and then Dentsply Sirona approached us to do their cone beam training, so we started to branch out there. And then we started going into other avenues. So no longer are we just with CEREC and cone beam, but we also do endodontic training, clear aligning orthodontic training, and implant training. So we moved now from CEREC doctors into CDOCS, a more complete education. Well, from a true abutment standpoint, that's in our provisionalizing and restoring implants with CEREC course. We go heavily in depth with tie-based solutions, being able to restore implants, but also provisionalize, making sure we have the tissue ready for the final restorations. So that's where true abutment comes into play. But with everything else, we have a vast amount of education that we can do here, all the way from CAD/CAM to placing implants, to planning implants, to cone beam, to diagnosing with the cone beam endodontic problems, and then also utilizing that with clear aligner orthodontic treatments.
Oh, there he is. Mark, how you doing?
Good.
Oh yeah, fist bump.
Fist bump.
So I like what you've done with the place
Yeah.
here. This place is really nice. You know, when I walked in the door, it felt like I was walking into an Ivy League college.
When I first came here, I called it Dental Disneyland, and it made the impression on me right away. And then we serve 2 meals, breakfast and lunch for everybody that comes on campus. So got all the safety precautions and everything else here with the arrows and everything else.
Oh wow, look at this. This is great.
And of course, being in Arizona, starting, I don't know, October or so, everybody sits outside, especially everybody from up north.
Yeah, absolutely.
They love the sun and everything else. So this is where we do a lot of our hands-on, especially with CEREC training.
Oh,
so,
this is amazing.
So once again, safety concerns, social distancing, and 3-to-1 screen up front, and this is where all the magic happens. Well, what CDOCS is planning for from an education standpoint, we'll continue with our hands-on, in-person training, but also we have a robust website that we're going to be doing some virtual trainings, some online trainings, self-guided trainings. So we have a whole lot we have planned in 2021 from an education standpoint. We'll give everybody different types of methods, how that enters into their practice, whether they want to travel, whether they want to stay at home, whether they want to have it done guided with an instructor, or whether they want to have it self-guided where they come and choose what they want to see.
Okay, so let me talk about the accuracy of the surgical template system. The first question is, how accurate is surgical guide fabricated? So once again, in order to make the surgical guide, we have to pass through the multiple steps. We have to scan the soft tissue scan with the intraoral scanner, and then we have to take the cone beam CT. We have to merge it. We have to print out, right? Yeah. So all the factors during the fabrication of the surgical template is called intrinsic error, and then the error after fabrication of the surgical template is called extrinsic error. Usually it is extrinsic the error is related with the surgical errors. So these are these small numbers at each step in fabrication of the surgical template. And then the most biggest error of the intrinsic error is caused by the so-called sleeve drill combinations. So that is the schematic picture of the sleeve drill combinations. So, but the concept is quite easy and simple. Yeah, it is not complicated as you see in this picture. Simply to say, the surgical drill is tightly guided by the surgical template. We won't have much errors. If the surgical drill is loosely held by the surgical template, we will have more errors. It's a common sense. So based on the journal, we have 4 factors which can affect the accuracy of the surgical template. So The first factor is the sleeve length. If the US company manufactures uses the long sleeve, yeah, it will the surgical drill more tightly, right? We will have the less error. But, well, if the US company makes the more clearance between the metal sleeve and then surgical drill, the surgical drill have the more wobbling. We will get the more errors. And then, if the surgical template is made with the more offset distance, with the longer implants, well, the unsupported length of the drill is longer than the other case. So which means at the apex area, because of the unsupported the part, we will get the more wobbling and then more angular deviations.
Would you recommend for guided surgery having smaller length implants because of that? They're more accurate?
If you want to do it, yes. And then yes. But usually, well, actually even in freehand technique, well, I do not place implant more than 11.5 millimeter. Yeah, maximum 12, right there. And then if I have to use the 13 and 15 millimeter of the implants, I just use it for the immediate placement. Yeah. So so in this sense, I usually place the 10 or 11.5 millimeter of the implant for the surgical template. Yeah. And then even though you use the 13 and 15 millimeter of the implants, actually deviation value is not that much great. Okay, so it'll be fine. And then the next one is the extrinsic factor. Actually, it is more actually we, as a dentist, we cannot control the intrinsic factor. That intrinsic error can be controlled by the company. So once again, extrinsic factor is called the surgical errors as well. So first of all, when you do the surgery, so you have to double check the adaptation of the surgical template. Okay. So you have to ask the lab to make some window here and there on the surgical template. So through that window, you can double check the fit of the surgical template. Okay? Don't just rely on the feeling of your finger. So once the surgical template is fit well, this is not enough. You have to wiggle it, the surgical template. If this surgical template is unstable, so you have to decide a lot of things. So for example, okay, you can abort the surgery, or you can go on with the stabilization of the surgical template, and then after placement of the initial hole, you can just double check with the X-ray with the guide pin as well. There's a lot of ways to overcome this the issue, but basically, so you have to do surgery with the well-fit surgical template. Yeah, or even though the surgical template is really well fit, another issue is if you bring the surgical drill with the improper angulation, eventually your surgical drill might have some kind of premature contact with the metal sleeve. Okay, so in this case, it will end up with the under drilling or the angular deviation, right? So we have to control consider lots of things. So the next question is, how accurate can the implant be placed with the surgical template? So when you read a journal, so you will find some variables to explain the errors. The blue one is the planned implant position, and then red one is the actually placed implant position. There's some discrepancies. A is the linear deviation of the entry point, and then B is the deviation value of the apex area, And then B is always bigger than the A, of course, by the angular deviation of the C. And then D is the vertical deviations. So the horizontal linear deviation of the entry point is usually it is quite small, below the 1 millimeter. And then, but the deviation direction it can be happen and everywhere. So at the apex deviation, so if the deviation value is less than the 0.5, between 0.5 to 1 millimeter, usually the direction occurs at the mesiodistal level, mesiodistal direction. But the deviation value is over 1 millimeter. Usually it occurs to the buccolingual direction. So actually the dentist is more concerned about the vertical deviation rather than the horizontal deviation, because we are afraid of the impingement of the implant to the some vital structures. So but I don't know if it's good or bad. Usually the vertical deviation occurs to the occlusal direction, which means we might have some under drilling or under placement, one of them. Okay. Well, there's a lot of reasons of the under drilling, because we might have some premature contact of the drill with the metal slip, or we might have some bone chips in the osteotomy, or the surgical template might be poorly fabricated from the, and one of the notable thing is, so we can have more vertical, we find the vertical deviations in the molar area than the front side. Maybe, so when you control the vertical, when you place the implant, so because of the lack of the vision in the posterior area, because of the trick tissue, maybe dentists might not place the implant all the way down. Maybe we cannot clearly see the surgical offset guided line to the flat surface of the metal slab. There are lots of reasons. And then, so what about the comparison of the accuracy between the planned position and the real position? So actually, this is the real value of the errors. Usually, the deviation value at the entry point is around 1 millimeter, and then deviation value at the apex area is around 1.5 millimeter, and the vertical deviation is around 0.5, and then angular deviation is around 5 degrees. So actually, we have lots of this kind of the papers for the last 10 years, but all the numbers are nearly same. So, but when I first read a paper, so I can fully understand, okay, 1 millimeter of the deviation, okay, that much. Okay, 1.5 of that much. Okay, but I couldn't get it. What is the meaning of the 5 degree of the angular deviation? So that's why I just made simulate the 5 degree of angulation with the computer graphic. So most of the left side is deadly accurate, no deviation, 0 to 0, and then the middle one is the 3 degree deviation of the implant placement. And then most of the right side is the 5 degree of the angular deviations. So so what do you think? So the 5 degree deviated implant, the implant placement, is it clinically not acceptable? I don't think so. It's quite clinically acceptable. And then to make the beautiful crown is more related with the position of the platform of the implant. Okay, as far as the implant position of the platform is on the right place, whether the implant is placed like that, it does not affect the clinical outcome a lot. What about the comparison of the accuracy between the freehand and then computer-guided the surgery? Actually, as you expected, the computer-guided surgery is much more accurate. Yeah. So, and then what about the difference of the accuracy between the inexperienced and then experienced dentist? We can find lots of the similar papers. So simply to say, we cannot find much difference between the experienced dentist and non-experienced dentist. So in this journal, they define the inexperienced dentist as the dentist who placed less than 20 implants. Every paper has a little bit different definitions of the inexperienced dentist. So anyway, which means with the little bit of exaggeration, even the new graduate dentist can place the implant as beautifully as the master implantologist, with the little bit of exaggerations. Maybe that's why nowadays lots of implant company, opens the basic course only with the computer guided, only with the surgical guide, computer guided surgical templates. But I don't know it's good or bad, but it's a kind of new trend. But basically, I don't like the trend. So first of all, experience does not mean the number of the implant you placed. And also the paper is just it is just someone's opinion. And then you have to just use the paper as the reference of your treatment. And then the protocol must be established by your own experience and then by the evidence. Okay. So when you start the new case with the surgical template, don't trust all the crazy papers. Just to start with the easy case first and go over one by one. So this is the benefits we can get from the surgical dentist, the surgical template. But actually, I just copy that paper from some textbook and then just copy it on my slides. But if you want me to pick up the only two benefits we can get from the surgical template, mostly from compared to the freehand. So I would like to say the first one is in case of the edentulous case. So lots of dentists, even though the experienced dentists have some difficulty to place the implant, to handle the implant in the edentulous patient. But why? It's just that we have to place only 6 implants or a maximum 8 to 10 implants in the one jaw. Why do we feel some difficulty? Because in edentulous case, there's no reference point. So at first time, so once the first implant is placed, the other implant is, the position of the implant is nearly already determined. The first implant is really important because once I said, the implant should be placed, when you place the implant multiple cases, so implant should be placed at least 3 to 4, we have to leave the bone between the 3 to 4 millimeter of the bone. So, and then all the size of the tooth is already researched. Okay, so for example, the molar to molar, we have to place implant around 9 millimeter apart. So when you read the paper or textbook, all the position of the implant between the implant position is already researched, studied at all. Yeah. So, but in case of the edentulous case, because of the no reference point, that's why lots of dentists have lots of difficulty to handle the edentulous cases. Another case is the cosmetic zone, the upper anterior area. So especially in case of the upper anterior area, implant position is the all about. So let me talk about a little bit more about the application of the computer-guided surgery on cosmetic zone. So, okay, let's vote. Which implant? So actually, I placed the 2 implants on each patient. Both are the same, the lower anteriors. So, what do you think? So, which implant position is better at a glance? Okay, so who vote for the upper one? Huh?
They look good, both of them.
What about the bottom? Who supports for the bottom one? Okay. The answer is, I thought both are good. Yeah, but actually it is not. Yeah. Oops, sorry. Yeah, this is the results. So just look at the emergency profile. In the bottom, yeah, well, even though there's some interproximal space here and there, but well, if you just look at the emergency profile of the implant, not bad. But in upper, the tooth number 25, this one, actually implant should be placed a little bit more mesially. That's why the shape of the implant looks like the banana. Okay, yeah, so it is well-known proverb. So 1 millimeter in cosmetic zone is equivalent to 1 mile on the road. So once the implant is placed, it is really difficult to change the final restorations. Okay, so in cosmetic zone, controlling of the emergency profile is a big issue, but how can we control it? First, so if we place the implant in the missing area, we have to make the emergency profile. But if we can have a chance to place the implant after extraction and then place the implant immediately, well, and then emergency profile is good before extraction, well, it would be better to preserve it. So, how can we create the emergency profile? Well, we can use create the emergency profile just with the stock healing abutment. Or the best way is to using the provisional crowns, and then maybe we can use the custom healing abutment. I'm not talking about the custom abutment, I'm talking about the custom healing abutment. So this is the classic type of the gingival molding with the provisional restoration. We have to create it. That's why they coined the name gingival molding or guided tissue. So the patient comes in to get the implant in the upper anterior area. 8 and 9 is missing, so the patient doesn't have enough bone. I did lots of bone. And then, but still, I do not have enough bone, so that's why usually in this case, if the patient does not have enough bone, that area in the upper anterior, the implant has a tendency to place a little bit more labial side. So I made a temporary crown with the PMMA. So when I make them, when I show the temporary crown to the patient is a little bit, not a little bit, a lot sad. So after 1 month, I did something. I just shaped down the cervical area to make the room for the soft tissue to come down. And this is the 1 month later. So patient is really happy, but I'm not happy yet. So I know I could something more. So I just a little bit more room for the tissue, for the soft tissue to come down. And then this is the another month later. And then I love screw retained restoration, even though the implant is placed labially. we can redirect the screw hole into the lingual side with the help of the angulated screw channel system. And this is a lingual, yeah. So this is the gingival molding with the traditional, provisional crown. And then another concept is using the custom healing abutment. So as I mentioned before, so even though we use the stock healing abutment, as far as implant is decently placed, and then as far as we can choose the right size of the healing abutment, it is not that much difficult to make the decent looking restoration. But the little bit downside of the stock healing abutment is the surface of the cross cut is always round. But in natural tooth, the cross cut of the cervical area is never be round. Each tooth has a little bit different shape, but no round shape. So that's why we have to understand how is the design of the custom healing abutment is supposed to be. So this is the before extraction and after extraction, after placement of the implant. And then this is the ideal shape of the restoration, which is the same shape of the natural tooth before extraction. So everybody knows the top of the healing abutment is should be positioned around 1 or 2 millimeters above the gum tissue. And then the cervical area, the dimension of the cervical area must be same as the final restoration. The reason is, if the final the dimension of the cervical area of the final restoration is same as the custom healing abutment, when we take out the custom healing abutment and then put the final restoration, there is no pressure on the soft tissue. If we do not give this soft tissue, give the pressure on the soft tissue, there's no gum recession in short term. So if we do not have the gum recession in the upper anterior area, well, at least we don't have any exposure of the metal structure. So I use the term short term because in long term, we have another factor, right? We have the oral hygiene maintenance and like that, okay? So this is the picture of the custom healing abutment, and this is the occlusal view. And then this is the comparison of the cervical dimension of the custom healing abutment on the right side, and then custom abutment on the left side. Okay, and then so when we have to preserve the emergency profile, yeah, traditional way is the chairside provisional restoration from the scratch. It's a really pain in the neck for the general dentist. First of all, you must have the eye for the beauty, and then you have the good hand skill, right? And then another way is to using the computer-guided surgery with the custom abutment and PMMA provisional restorations. So the patient comes in to get the implant on tooth number, actually not 6, it's a C. So this is the totally floating, it's a baby tooth. So I did soft tissue scan, hard tissue scan, and ordered the surgical template, and then provisional crown, and then custom abutment. And then take out the tooth, and then this is the soft tissue after extraction. Wow, how beautiful it is. Yeah, I just want to keep it. So the implant is placed with the surgical template, and then this is the hex timing. Now you are really get bored with the same picture again and again and again, hex timing, but we need it to place the temporary crown just right after surgery. So, okay, this is the after delivery of the final restoration. So how is it? There's no blanching on the soft tissue. Okay, so we can preserve the soft tissue beautifully, okay, without the much efforts. This is a pre-op and post-op, and then, so we have this guided surgery is now getting more and more popular. So many people say we have some big issue to use the surgical template. The main reason is the time and money. So I don't know, it is good or bad again, but nowadays more and more general dentists in Southern California try to place the implant from the moment when patient comes in. So I do not think it's a healthy trend, but it's a trend nowadays. But if you use the surgical guided template, we need at least 2 weeks to get this case back from the lab, and also we have to pay the lab fee. And also, eventually we have to buy the cone beam CT and then intraoral scanner. It's a big investment. But personally, we have more big issue. So the reason why the general dentist does not use the guided surgery is they have some kind of misbelief. First misbelief is all implant can be placed perfectly by free hand. But actually, this sentence is false. Implant may be placed perfectly by free hand, but you must have an ability to place the implant perfectly with your hand, with the free hand, even your mood is bad. Okay, you have to control, you have to maintain your quality of the treatment. So another misbelief is male post-implant can be solved by the restoration. Actually, it is wrong. So we can improve the final restoration with the help of the custom healing abutment or the change of the material. But actually, once the implant is misplaced, we cannot get the restoration as good as the restoration which is supported by the well-placed implants. Okay, so this is the take-home message. So almost done. The dental implant can be placed with the predictability and then accuracy with the computer-guided surgery. And then computer-guided surgery shows some degree of the deviation values, but it does not affect the clinical outcome. And then computer-guided surgery is not the money-making item, but the quality-making items. This is my opinion. Okay, thank you for listening. Okay. So do you have any questions?
No questions? Any questions? Or go back to some of the guided surgery? This is perfect time.
Okay, thank you for coming again. Thank you.
So I'm here and they're getting set up ready for a beer and wine and some food, you know. So enjoy, please stay. And there's a couple of people I want to talk to. And any questions that you can grab Dr. Choi and myself and ask any questions.
Yes, and then there's my email.
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
Welcome to another episode of True Abutment's Interview.
Always invest in yourself. You have to be first.
welcome to another episode of True Abundance Interview.
She doing for herself, I applaud her. No need, yeah, I'm talking my boo. So please, leave me alone, I do. And it's all cause what you started. I haven't told you I'm gonna steady calling my phone. I done told you before that it's over. Leave me alone. No one's hurting you to see me gone. Dark clouds, you gon' see me storm. I won't go.